Thank you. Very good morning to everyone, and I would like to thank the organizing committee for this opportunity to speak. So I'm Dr. Wei Yan Ng from Singapore, and today I'll be speaking on when is a seemingly when is a seemingly common esotropia dangerous, right? And these are my financial disclosures. So I'd like to present on the case. So this patient on presentation was a 29-year-old male that came into Singapore National Eye Centre a few months ago into our general clinic. And his main presenting complaint was actually that of a 2 weeks worth of a torsional diplopia, which he did not present with or complain previously. And overall, the progression was that it was actually gradually getting worse over the 2 weeks. And he was actually a known patient with previous ocular issues before, and his last review was in 2 years ago, of which he has defaulted. So overall, his medical condition, he has seen multiple hospitals as well as a fragmented medical record. So some background, back in 2008, he had large cell medulloblastoma in his intracranial medulloblastoma, of which he then underwent surgical debulking and chemotherapy. And at that time, an external ventricular drain was inserted, of which he then developed some complications. And subsequently, about 1 year later, due to hydrocephalus, it was then switched into a ventricular peritoneal shunt. And after that, he had no hydrocephalus, and based on his last report, which we have no images because it was done in another hospital, 6 months ago, the last MRI was actually reported as pretty stable, though there was a hint that there was a slight increase in lateral as well as the third ventricle. Right? In terms of the ocular dysfunction, so since the diagnosis, he has been having a chronic left sixth nerve palsy as well as a concomitant LHT that actually developed much later, back in 2020, about 5 years ago, just at the start of COVID. And since then, he was on grinding prisms, of which he has actually been coping very well, no torsional diplopia complaints. So this was his examination. Visual acuity was good, and then he had a left esotropia of about 10. That was a bit incomitant, especially worse on the left gaze with a bit of a left hypertropia. And overall, based on that examination then in the general team, there was a slight minimal limitation in abduction of the left eye without any significant vertical overaction or underaction. And at the time, the double Maddox rod showed that there was some degree of axial torsion. Right? And crucially, there was no papilloedema when we examined the fundus at the time. And so he was given just a routine follow-up to the pediatric clinic, of which he then postponed, and he came in 2 months later. Right? And this time he complained of increasing torsional diplopia. And this was his examination. Again, visual acuity remains good, 6.7.5, and the esotropia as well as the hypertropia actually remains pretty stable. Less of an incomitance in this visit, but that might be due to a bit of variation. So during my examination, there was actually a little bit of, there's a bit of SO underaction in both eyes, as well as a slight limitation in the abduction of the left eye, with a bit of an inferior oblique overaction. And at that time, the double Maddox rod showed there was an increase in the axial torsion, especially in the primary as well as the inferior gaze. And crucially again, there was still no diplopia. So basically this patient has increasing diplopia but not worsening esotropia and no clinical signs at that moment of papilloedema or raised intracranial pressure. And symptomatically no giddiness or headache at that moment. Right, so this is his nine gazes facial photo. He has slight left gaze limitation, as well as a bit of limitation of the superior oblique. So this is the left eye, the adductions of the left eye, of which again there's a bit of limitation of the superior oblique. And this is the night gaze photo of the right eye adductions. And this is the widescreen, of which it showed significant axial torsion in both eyes, with and without fusion. And this is the fundal photograph. As you can see, there's no disc swelling, and there is with the line drawn, there is a bit of axial torsion present in both eyes. And so in view of the recent changes, I decided still better to just, even though there was no increasing esotropia that might accompany the sixth nerve palsy, I decided to schedule a repeat MRI, even though 6 months ago everything was cleared by the neurosurgeon. And then the radiologist calls on a Sunday evening, immediately after the MRI has been done. So this is the video of the magnetic resonance imaging, of which you can see that there is now enlarged ventricles, even though that the VP shunt is in situ. Right. So I just replay it one more time before we move on. Okay. And so this is the comparison. We had one MRI back in 2017 where he was done in one of our main institutions affiliated with us. So this was the 2017 MRI, and this is the 2024 MRI that was done. And so it shows stable position of the BP shunt, but there was significant hydrocephalus with mass effect as well as effacement of the basal cystins. But luckily, no new lesions were seen at the moment. And so in terms of progress, he was then called back urgently and then admitted to neurosurgery, where the shunt was then interrogated by the neurosurgeons. And they found that there was actually no obstruction. Curiously, the pressure was actually normal, and all the other metabolic tests as well as cultures were normal for the CSF. So it was finally determined that this is likely secondary to a shunt malfunction. And review after about 1 to 2 months after that interrogation, where everything was cleared, he came back with improving torsional diplopia. So vision remains stable, 6.5 both sides, as well as left esotropia and left hypertropia, which again is still relatively stable, though there is a little bit of an improvement on the left gaze this time. And in terms of the overall movement, we do not have a repeat fundus photograph, but there is a reduction in the excyclotorsion in all gazes in the vertical gaze. And again, there was still no papillary edema noted on fundal examination. So in summary, increasing hydrocephalus might not present with papillary edema that we know, but in a patient with a known sixth nerve palsy due to the intracranial lesion, increasing hydrocephalus might not directly affect that sixth nerve, which has already been compromised. And something that if it presents atypically, it should, especially with a history of intracranial lesion or intracranial surgery before, then it's still better to order a scan on the safe side so that we can detect certain atypical presentations like this. All right. And with that, I would like to thank you for your kind attention.